Thank you, Kate, and distinguished guests. Social injustice is killing people, and I want you to meet 3 people who are going to help me illustrate this. First of all, Jenny. Jenny is a 39-year-old single mother. She's got 2 children, aged 12 and 8, and she lives on the Aids housing estate in Campbelltown in public housing. She moved to Sydney from the country when she was in her 20s, and it hasn't quite lived up to all she'd hoped from the bright lights of the city. She's recently been diagnosed with type 2 diabetes. She knows that being overweight and smoking doesn't help with this. She works part-time as a home carer for older people, so she doesn't have much spare cash because she only earns $26 an hour. Often she's rushed in the morning. Her 12-year-old son has learning difficulties. He's very hard to get up and get ready. She drives the children to school so she can get to work on time. And it often means she stops at McDonald's and grabs a quick breakfast for her and the kids. She knows those donuts aren't good for her, but it is quick and it's relatively cheap. Often in the evening, she'd like to prepare a healthy meal, but often a pizza or chips is much easier. The kids like it and it is cheap. She's really trying to quit smoking, but it's one of the few pleasures that she has, sitting down with a fag and a cup of coffee. The kids leave her alone. She doesn't have much time to socialize, given a job, given the demands of the kids, and she doesn't know that many people in the area of Sydney where she lives, so she feels quite unsupported and quite lonely for adult company. She often feels depressed about her life, and she's taking antidepressants, which she doesn't like because she feels they've made her put on weight and she believes they really drain her energy. So that's Jenny. Now let me introduce you to Jimmy. Jimmy lives in Alice Springs in the Northern Territory. He's 47. He's an Aboriginal man who was part of the stolen generation, and he suffered from the trauma and ongoing grief that stemmed from that experience. He was removed from his family, which was in a remote community on the borders of the Northern Territory and South Australia, and he was brought up by a white family in Adelaide. In the past, he's drunk too much alcohol, and he used to smoke. He also suffers from depression, and he's a little overweight. He's currently employed as a male health worker in an Aboriginal-controlled health service. And since he started this job, he has managed to give up smoking, and he's really reduced his alcohol consumption. He has early signs of renal disease, but that's being monitored by his GP. The job gives him a chance to work with Aboriginal people, and what he really loves about that is he can help ensure that the health service is culturally appropriate. He's a father of 2, and thanks to a first homeowners scheme, he's even managed to be buying his own house. But he's very worried because the program he's working on has 3 years funding from the federal government, and he doesn't know if that contract's going to be renewed. And if the contract isn't being renewed, he'll lose his job. And then the third person I want you to meet tonight is Emmanuel. Emmanuel lives in Sierra Leone. He's 28, and he works there for a Malaysian logging company. He has to work incredibly long hours. He had 3 children, but his youngest, a 3-year-old girl, Fatu, died from Ebola earlier this year. His wife works as a nurse at the local hospital. She contracted the disease at work and brought it home, mainly because the infection control available at the hospital was so rudimentary. Emmanuel counts himself lucky that his wife survived, because about 60% of the people who went to the hospital with Ebola died. His daughter wasn't very healthy when she contracted Ebola. She suffered from repeated bouts of diarrhea. The family lives in a house that doesn't have running water or sanitation. They have to collect their water from a well, which is about 500 meters away from the house, and they have to defecate at the river that's running behind their house. Fatu was also undernourished, so was in no state to really fight the disease. And it's not surprising. Sierra Leone, according to the UN Human Development Index, is very, very near the bottom. And the country has suffered from years of civil wars. Emmanuel and his family live on about $1.75 and have no money put aside for emergencies, and they really do scrape a hand-to-mouth living. Obviously, Ebola has put considerable stress on the family. The grief of losing their daughter, the fact that his wife was unable to work for months, And the eldest son, who's 12, has had to leave school so that he can earn some money. They also had to pay fees for the hospital where their daughter was until she died. And all this is at a time when it's been announced that Sierra Leone has one of the highest growing economies in the world, and many foreign companies are making huge profits from the country. So Jenny, Jimmy, and Emmanuel's story really point to the texture and pattern of the unequal world we live in. Health itself is unevenly distributed. In Campbelltown, where Jenny lives, the standardised death rate is 119. That's more than double the 56 of Wallara. Jimmy, as an Aboriginal man, knows that he and other Aboriginal people are likely to die 11 years before other Australians. And Emmanuel lives in Sierra Leone, which has one of the lowest life expectancies in the world at 45, compared to about 80 in Australia. Now, we know that the relationship of health to socio-economic status is linear rather than threshold, so this isn't only about the absolute poor, but it's also about the people in between whose health would be worse. So, while Campbelltown is just about at the bottom of the New South Wales league table for death rates, there is a gradient. Bankstown and the Blue Mountains are about near double the rate of Wallara. Sutherland Shire is about 1.5 times, and Stratfield about 1.7 times. So this really does operate as a gradient. And such gradients are repeated in just about every country you look at, and of course within countries, between countries globally. Those inequities are underpinned by social and economic inequities. Health and its determinants, I think, operate like an iceberg. So mostly what we see is the tip of the iceberg. So you see whether people are sick or healthy, and I think that's particularly the case if you're a doctor or other health professional. Yet below that iceberg, below the surface, it becomes clear that there are many other factors that affect health and health inequities. Yet what I notice is that people very often focus on that tip, and they'll say that, well, people are in bad health because they have unhealthy lifestyles or they have poor behaviours, and they in effect blame people for their sicknesses. But in fact, most people's behaviours, their lifestyles, their sicknesses, their illnesses are a result of those factors that lay below the surface, and mainly they're invisible. Now, one that I think has a really strong effect, a below the iceberg effect, is the way that we distribute income and wealth. About a decade ago, economists were debating about whether the world was becoming a more or less equal place. But I think now the jury is in, and economists and others agree that all indicators suggest that we have growing and greatly increasing inequities. A recent Oxfam report noted that the 85 richest people in the world, that's just 85, so less than the number of us in this room, holds as much wealth as the bottom 3.5 billion. An astounding fact, and we live with that. Many of you will have read of the work of the French economist Thomas Piketty, who has demonstrated the rapidly growing gaps in wealth between the top 1% and especially the top 0.1% of wealth holders. In Australia, Andrew Leigh, MP and former ANU economist, in his book Battlers and Billionaires, describes what he calls the Great Divergence. This has seen the gap between the top 10% of wage earners and the bottom 10% of wage earners grow significantly. Now, if workers such as Jenny had experienced the same wage growth as the top 10% of earners, then the average low-income earner would have an extra $14,000 per year. For Jenny, that would equate to earning another $7 an hour, and you can imagine what a difference that would make to her life. Andrew Leigh also notes that in the 20 years to 2009, the average earnings of the top 100 CEOs rose from 1 million, which was 17 times average earnings, to 3 million, 42 times average earnings. He also points a similar picture in regard to the wealth held by what he calls the super rich. He estimated that from the early 80s to 2012, the richest 0.001% more than tripled their share of household wealth. In other words, inequity grew considerably. Not surprisingly, Aboriginal Australians such as Jimmy receive only a tiny share of the nation's wealth. As one indicator, Jimmy is unusual in owning his own house. Only 30% of Aboriginal people do, compared to 70% of the rest of Australians. And looking internationally, of course, income distribution is even more unequal. Australia's gross national income per capita is somewhat over $40,000 a year. In Sierra Leone, it's under $2,000 per year. Now, I spent 3 years with my colleague Mireille Chatterjee, who's with us today, as a commissioner on the World Health Organization's Commission on the Social Determinants of Health, which was chaired by Michael Marmot, who's just taken over actually as president of the World Medical Association. And after we looked at the evidence, we concluded, to quote, "Social injustice is killing people on a grand scale. This unequal distribution of health is the result of a toxic combination of poor social policies and programs, unfair economic arrangements, and bad politics." So thinking of Jenny's diabetes, it would be easy to say that she doesn't help herself by eating too much fast food, by smoking and not exercising at all. Yet she lives on the breadline, she's time poor, she works in a very demanding job, she cares for her children, she lives in a suburb that isn't very safe, isn't very encouraging to walk around, she's socially isolated and she's depressed. Likewise, Jimmy's health has been greatly affected by all manner of below-the-iceberg factors. As part of the stolen generation, he was more likely to suffer addiction, be imprisoned, and experience mental illness. The loss of land and culture, of course, has had a huge impact on Aboriginal people. We know that. It's very hard to precisely calculate that effect, but it's nonetheless very real. Aboriginal people are less likely to finish school, have a job, and if they have one, they'll earn less. They're also subject to daily racism. We conducted a study in Adelaide in 2009 looking at Aboriginal people's experience of racism. And Gilbert Gallagher, my Aboriginal co-researcher, spoke to very many Aboriginal people in Australia. And when I read the transcripts that he brought back, I was quite shocked by the level of racism that people were reporting in suburban Adelaide. Just to quote one of the men in our study, he said, "If you get slapped down for so long, if you're ignored and if you're pushed to one side, then that affects your health. That affects your mental health, your physical health. You end up smoking, you drink, you become frustrated, you get violent, and it not only affects you, it affects the people around you." So all these factors are there below that iceberg, and they really do account for why Australians die so much earlier, why Aboriginal Australians die so much earlier than other Australians. Now, it could seem that Emmanuel's experience with Ebola was just bad luck being part of an epidemic. Yet my colleagues in the People's Health Movement, David Sanders and Amit Sen, point to the social and economic roots of the Ebola epidemic. Those roots include poverty, poor living conditions, and make it extremely likely that any infectious disease will spread. The fact that poverty drives people into the forest to look for food and fuel, where they're more likely to encounter the fruit bats that carry the Ebola virus. Overseas agribusiness have been buying up land for maize and soybean cultivation, and biofuels as well. Mining and logging companies have also increased their activity. And this increasing activity has led to deforestation and penetration of new roads into what were previously very remote forest areas. Many local people have been displaced by this new economic activity and also by years of civil war. There's also been less rainfall in West Africa. People suggest that may be climate change, and maybe also worsening the situation of people like Emmanuel. I think Sierra Leone is so poor is also a reflection of its colonial history, where many of its resources were taken by Western countries, including through the slave trade. In the 1980s, Sierra Leone suffered from structural adjustment programs imposed by the World Bank, which prescribed spending on welfare and health services, and partly accounts for the state of the health services currently in the country. The depleted nature of the health service is also made worse by the brain drain, or what my colleagues in Africa call brain looting, by which doctors and nurses move to rich countries. So in Australia, we have 3.3 doctors per 1,000 population and 10.6 nurses. In Sierra Leone, they have 0.02 doctors and 0.17 nurses. That's a real inverse care law. Those that have the most need for health services have the least means to do something about that. And finally, Sanders and Sen point out that although the Ebola virus has been known for 40 years, no vaccine or remedy has been developed. They put this down to the fact that pharmaceutical companies haven't been interested. They're much more interested in finding cures for diseases of the rich rather than diseases of the poor like malaria and TB. And they say that Ebola was one of those until it began to threaten Western countries. So thus, I think you can see that the underlying social and economic determinants of health are very powerful in shaping our everyday living conditions, our housing, our employment, but also shaping the factors that determine things like our housing and employment, like the distribution of income, of wealth, of how much power people have. Now, when Diane, James and Andy, who convened and have so well organised this oration, contacted me to give it, they asked me to address the ways in which the growth of personalised medicine would affect equity. And I thought, well, I don't know much about personalised medicine, but I do know about equity, so this is a challenge that I'd like to take on. And I think that question can't be considered outside the context of the social determinants of health and access to health services. Now, we know that access to good quality medicine and health services is very important to our health, but estimates suggest that probably the contribution that's made is something between 15 and 20% to life expectancy gains in perhaps the last 50 years. And that means, I mean, that's a really important part of the game, but there are also many important ways in which social determinants of health determine who does and who does not get access to health services. So if we think about Jenny faces many more barriers to good health than would, say, a person living in Seaforth. Her local general practice doesn't routinely bulk bill, so she faces a co-payment when she or her children go to the doctors, and that means she often puts off going, and very often that means they're sicker when they do go. She's employed on a casual basis, so if she wants to take herself or her children to the doctors, she misses her pay. She doesn't get any sick leave. And when she goes to that doctor, she really dreads the fact that she'll get a lecture about her smoking, which, as I've said, is one of her few pleasures, and the fact that she's overweight. The one thing that has been helpful to Jenny has been her local community health centre, which ran a support group for people with diabetes and also provided childcare, which meant she could actually go. She found the support of other people with the same problem and wanting to ask the same question was very helpful. When she visited the doctor on her own, she was often very scared to ask those questions, but for the risk of appearing stupid. But when there were other people asking the same questions, she felt much braver. That centre has also started a fruit and veg co-op and has started selling cheap, fresh food at an affordable price, and that has been encouraging her to cook healthier food. Now, Jimmy has been much luckier, really, with his healthcare. He uses the local Aboriginal community-controlled health service, where he's also employed, and the primary healthcare service offered him there is totally free, and it's a very well-integrated multidisciplinary care that he gets. And he feels that the GP and the rest of the multidisciplinary team are very committed to preventing his early renal disease. He's also participated in a number of group support programs, which has seen him through his depression, and he finds that depression is much less of a problem for him. He's also, through that group process, reduced his overuse of alcohol, and it's given him an extremely supportive environment where he's been able to confront the demons from being part of the stolen generation. Of course, in Africa, health services are completely depleted. They create risks of infection and are completely under-resourced. Emmanuel's wife is very aware of that problem as a nurse at the local hospital. There's been a shortage of infection control gloves and masks, a chronic shortage of staff, and very often a shortage of drugs. The service is basic, it offers no thrills, and personalised medicine would only be a far distant dream. So I think this raises the question of what is personalised medicine, and the reading I've done about it since I got the invitation suggests that there is a lot of hype about personalised medicine, and it clearly has huge potential to improve treatment. However, I think it does raise the question of what is health and what is its ultimate purpose, and is it to live forever? And it reminds me of a story I like to tell of my early days working in health promotion in Noarlunga. Noarlunga is a southern suburb of Adelaide with quite a high number, a bit like Campbelltown really is to Sydney. And I was very gung-ho about the New Healthy Cities project and health promotion and saying how fantastic it was. And then a little old lady, a British immigrant, put up a hand and said to me, "Excuse me, dear, but what are we allowed to die of?" And that really got me thinking about, well, yes, there is a point there. What are we allowed to die of? So I think the question is, how does personalised medicine fit within equitable health systems? Who will have the best access to what it offers? And it's highly likely to be those groups who already have good access to health services. And of course, it intervenes when people are sick rather than keep them well. There are massive disparities in the world concerning who gets access to care, and real tensions in the way in which we are focusing on more and more high-tech medicine, which will benefit a few and generally not impact very much on public health, and that will also take away resources from developing the good basic primary health care that Jenny, Jimmy and Emmanuel need primarily. When I was discussing this oration, I was recently in France on holiday with my very best friend from England, Pauline, and I was telling her about this oration and saying I'm quite nervous because I'm doing it without PowerPoint. And she said, well, what is personalised medicine? And I said, oh, well, you know, it's about improving healthcare by using biological information and biomarkers, looking at the level, you know, looking at molecular disease levels, looking at disease pathways and genetic information, and gave her a somewhat scrambled explanation of it. When she heard that definition, she was very surprised, and she said, well, I thought personalised medicine would be much more about tailoring health care to the cultural, economic and social circumstances of people. Perhaps it should. So, what I want to do next is take you on a little historical voyage. My first degree was in history, and I've always found that history offers really important lessons for public health. And this is despite the fact that I noticed that many hatchet-wielding vice-chancellors are busily defunding history departments, because I think they see, without any irony, that history is really a thing of the past. But despite that, I think that history has is a very important discipline. And I know at Sydney, you've had a really strong tradition of history of medicine and history of public health. And there is a classic, well-worn story of public health that all of you who have worked in public health will know. You will be able to chant it like a mantra. And that's the work of Thomas McEwen, who was a doctor who pointed out that the assumption that the reason we had extended life from the end of the 19th century to the mid-20th century was because of medical intervention. And he said, well, no, that actually isn't right, because the advances in life expectancy happened before we had those medical interventions, such as drugs for TB. So he said, well, it really was living conditions. So when people first moved into cities, life expectancy absolutely plummeted, so that in Manchester in about 1828, life expectancy was as low as 28. That's as long as people were living when they first moved to those cities. Then food improved, housing and sanitation, clean water was provided, and life expectancy increased before there were effective medical interventions. Very interestingly, I think Cambridge historian Simon Schreiter added an important part of the jigsaw to the McEwen story when he said, yes, improved living conditions were vital, but they only actually happened because of popular struggles and social movements for those changes. So he points to the way that trade unions lobbied for improved working and living conditions. And he said that there were many municipal movements arguing for better town planning. One of those was the Healthy Towns movement in the mid-19th century that advocated for clean water, for better sanitation and better housing. So all those things made a big difference. And if we look back to 19th century commentators, the issue of diseases affecting the poor more than the rich was still very evident. So Friedrich Engels, who of course went on to have an alliance with Karl Marx, provided a clear picture of the relationship between people's working and living conditions and specific diseases in his mid-19th century report, The Condition of the Working Class in England. He argued convincingly that the ability to resist disease was a reflection of an individual's class and social position, which meant that changes to working and living conditions were what were going to be influential in preventing diseases. Similar conclusions were reached across the Channel in Prussia, where Rudolf Virchow produced a report on a typhus epidemic, noting again that it was the underlying social and working conditions that were important causes. He made recommendations for improved nutrition, more employment, better housing, and free public education, because we know that education is a very strong determinant of health. Based on his experience in Prussia, he made the very famous comment that's become a sort of dictum now, that medicine is a social science and politics is nothing else but medicine on a large scale. So medicine is a social science and politics is nothing else but medicine on a large scale. And I think the second example from more recent history that I want to give you really illustrates that dictum. We've seen that we're growing more unequal, and in their book, The Spirit Level, Richard Wilkinson and Kate Pickett provide evidence that societies in which income is equally distributed, usually measured by a Gini coefficient, so the lower the Gini coefficient, the lower the level of inequity, then the better a society fares in all sorts of ways, in terms of crime rates, measures of psychological well-being, measures of child well-being, whether or not the society is socially cohesive, and of course life expectancy. So I think it's this issue of inequity that is part of the reason that the richest country in the world, the US, does not have the highest life expectancy. So let me compare the US with one of its southern neighbours, Costa Rica. In the US, the gross national income is about $53,000 per year. In Costa Rica, it's a little under $10,000 per capita per year. Health expenditure per capita in the US is now around $9,000. In Costa Rica, it's $1,300. On a Happy Planet Index that kind of measures ecological footprints as well as life expectancy, Costa Rica rates number 1, so that would suggest it's the most sustainable place on the planet, and the US ranks 105. But what would you think about the life expectancy? In fact, in Costa Rica, people live for 1 year longer than the US. On average, they live 79.7 years. In the US, they live 78.7. So other countries have achieved good health at low cost from the 1940s to the 1990s. They number Cuba, Sri Lanka, China, and Kerala State in India. And generally, analyses that have been done on the phenomenon of health without wealth suggest that it's based on greater social equity, good primary healthcare services of the type we've already heard a bit about, decreased income inequity, improved status for women is really important, especially literacy for women, the availability of family planning, which leads to lower birth rates, land reform so that people can own their own land, and of course adequate physical infrastructure that we saw in the 19th century, water, transport, and electricity. Now, in these countries, infant mortality rates have been much lower than in other low-income countries. So, and unlike Emmanuel's daughter Fatou, children haven't died needlessly of entirely preventable diseases, simply because in most cases the provision of clean water and sanitation. Generally, the health without wealth countries have given top priority to meeting the basic needs of their populations rather than following the growth at all costs model, which hopes for some trickle-down effect. And I think the countries show that economic growth does not guarantee good health. It shows that the crucial thing is, how do we distribute the fruits of economic development? Do we do that equally, or do we concentrate it in a few people? If you concentrate it in a few people, it appears that it's not so good for the health of everybody. And I think it's interesting that the US is growing rapidly more unequal, and there's now evidence that life expectancy for low-income women in the US are actually declining for the first time in a couple of centuries, which is a fairly remarkable fact, I think. So my lecture's addressing the question of how we create healthy societies, and I want to take 2 points here. I want to look at how can we make our health services accessible and equitable, and convince you that I've got a few answers for that. And then secondly, I want to talk about making health in all policies a consideration across society. Now, I think personalised medicine, as I said, does have a lot to offer. But I would submit that we should get the basics correct first. In the middle of the Second World War, when Britain was fighting Hitler, the British did an amazing thing, really. They commissioned a report on social security, and they looked forward to the end of that war, which, given the Blitz and given the threat of the war, is a fairly remarkable thing. And its author, William Beveridge, who's now labelled father of the welfare state, set out a practical programme for that welfare state, which he called putting first things first. In his words, there was, quote, to be bread and health for all at all times, before cake and circuses for anybody at any time. So what is the bread of the health system? Now, I don't think it necessarily has to rest on high-tech solutions. And I think this well-worn story kind of illustrates that. I'm sure you've heard of the fact that NASA, when they first put astronauts into space, discovered that ballpoint pens didn't work. So they spent, I think it was about 12 years and literally billions of dollars developing a space pen. And we've all seen those lovely space pens that can write on glass, that work whether it's below freezing or 300 degrees centigrade. So they solved the problem. They could write in space. At the same time, the Russians were using a pencil. So what I'm asking in medicine is, are we creating NASA space pens in medicine, or are we creating pencils? Now, the World Health Organization promotes the pencil approach to healthcare and argues for strong primary healthcare, which stresses disease prevention and promotion as the best way of the health sector contributing to health equity. And the work of Barbara Starfield and others have shown very clearly that those countries that achieve the best health outcomes from their health services really rest on a strong primary medical care system. Now, in Australia, we've been a pioneer of innovative primary health care through our community health services, which I think have major benefits, especially in serving those people who don't have social determinants working in their favour. Sydney was the site of the first Aboriginal controlled health services in Redfern, in other words, where the community ran the service. And this movement itself was very influential in shaping the World Health Organization's Alma Ata Declaration on Primary Health Care. And in fact, your Deputy Vice-Chancellor of Indigenous Strategy and Services at this university, Professor Shane Houston, was present at the now famous Alma Ata meeting in the former USSR in 1978. And he brought to that meeting, as a young Aboriginal activist, the very important lessons from Aboriginal community-controlled health services. And I think those services continue to lead the way, even though it's not very often recognised. We've recently done a piece of NH&MRC funded research, and we found that the Central Australian Aboriginal Congress stood out as an excellent model for dealing with chronic diseases like diabetes and depression, offering a joined-up service from medicine, nursing, dietetics, podiatry, psychology. So really encouraging communication and really minimising the chances of people falling through the gaps, despite the extraordinarily difficult social and economic circumstances of many of the people that they serve. And I think it was such a service that Jimmy really benefited from. Now, I would love to see a community-controlled primary health care for every community in Australia, to coordinate care for all of us, rich or poor, healthy or unhealthy, male or female, young, middle-aged, old, long-standing resident, newly arrived migrant, Indigenous or non-Indigenous. Such a service could provide coordinated care for physical and mental health issues, work closely with the local hospital and hospices, run groups for people to improve their self-management of chronic diseases, cope with stressful life events like divorce, violence, unemployment. It was such groups that proved so useful to both Jimmy and Jenny. It would also be a focus for disease prevention and health promotion, and it could advocate on behalf of its community, as many community health centres do, picking up on issues of local pollution, domestic violence, or whatever issue concerns the community about their health. I think community health centres have already shown that they can be welcoming, they can be buzzing places, they can be a hive of health with community cafes, they can be a place, particularly in poor communities, where they become the heart of the community and offer a welcoming embrace for those who are sick or troubled, a truly personalised approach, I think. And working well, such a network of community health centres would reduce the demand for hospitals and keep communities healthy and well. So that's my point about the accessibility of health services. I now want to think about how can we ensure that health is a consideration across society. And I think one of the things that we argued in the Commission on the Social Determinants of Health is that the extent of health equity is a good indicator of how well a society is doing. And I think it's really good we're now at the stage where the federal government reports annually on how we're doing to close the gap between Aboriginal and non-Aboriginal life expectancy, and has set closing that gap as a national target, and that it has tripartisan support. But I think we need to do this for other health inequities, including those that result from socio-economic status, gender, and urban and rural differences. So if we had such a national goal, it would have Jenny's chances of dying prematurely much the same as a woman on the North Shore, Jimmy's the same as non-Aboriginal Australians, and Emmanuel and his compatriots the same as Australians. And that could be achieved. But we won't achieve such a goal unless we make each sector accountable for its health impact by adopting what's being called the health in all policies approach. And this means that governments' policies outside the health sector must come to concern themselves with health. And I've just got time to give two examples. One will be from urban planning and the other concerning employment. So in terms of urban planning, it's a question of asking how can we take health into account in how we plan our cities and communities? How can we do that so that they promote rather than detract from health, including, most importantly, the health of the planet? Which forms of transport will bring most health benefit? Which will do least damage to the planet? Who benefits from our current system of transport provision? Who loses out? Does it encourage us to be active? How can we ensure that planning doesn't just benefit developers who want to make a profit, but is also concerned with health? Now, despite former Treasurer Joe Hockey's assurance that poor people don't drive cars, it's actually very often poor people who live on the urban fringe, where public transport is very bad, who have to have two cars so they can get to work, they can transport their children around, they can have a social life. And it's now increasingly recognised that environments that are car dependent also do not encourage exercise. And they may encourage diseases. They are so-called obesogenic environments, and they will encourage people to be sedentary and develop diseases such as diabetes. So if we think to the area where Jenny lives, it's not served by good public transport, it doesn't feel safe to Jenny, which does one of the reasons she's reluctant to walk her kids to school. Her environment isn't very green and clean, it's not pleasant to take a walk in the evenings. And such suburbs are also unhealthy for the environment, as they're highly dependent on fossil fuels, and they're highly typical of cities like Sydney, which themselves are highly carbon dependent. But instead, imagine if we took health and well-being into account when we planned our cities. I think Sydney might look somewhat different. You might have better public transport, which I'm sure you'd all like. You might have cheaper housing, which I'm sure those of you who don't own houses would like. It would be more livable for all its citizens. There'd be suburbs designed to be ecologically sustainable, with low energy and fossil fuel use and high energy use for our bodies. Many suburbs would incorporate what we used to call in England allotments or community gardens and offer much more sustainable food supplies. Such cities would also rely on participatory planning processes and much less influence from those who make most profit from planning decisions. Some cities are planning for health in that way. In Europe, the World Health Organization has a network of healthy cities, and a lot of their focus in the last few years has been on planning healthy and ecologically sound cities. So the next area I just want to give an example of health in all policies is employment. We know that work has a profound impact on our health. All of us who work know that. It can give us a great sense of meaning and purpose and enables us to achieve many collective things through our individual labour. Education institutions like this, building cities, providing the internet, providing restaurant, health and other services. But our conditions of work differ considerably. It's a gradient again. And does our work provide social contact and support? Is it as meaningful as possible? Does it provide a living wage? Do we have a safe work environment, or is it prone to accident? And if you think about Emmanuel, he works in a highly dangerous industry, logging, and he earns very little. There's a high rate of industrial injury, and the Malaysian company he works for, like most of the other companies in Sierra Leone, take very little note of occupational health and safety, and there's very little regulation. Even though we know that regulation is really important to safe working conditions and is in place in most OECD countries. Cross-nationally, we know it's much safer to work in some countries than others. So if you work for BHP in Australia, you will have a much lower rate of an industrial accident than if you work for the same company, BHP, in South Africa. And the difference is that Australia has a whole set of occupational health and safety regulations that mean that the company has to obey those. The other factor that I'd like to look at to do with control is to do with control and health. And a lot of epidemiology has shown that health at work and how much control we have is crucial. This was shown in the famous Whitehall studies of British civil servants. And of course, no British civil servants are poor, but there is a gradient again of how much they earn. And the epidemiology showed that one of the most significant factors in determining whether those public servants died early was the amount of control they had over their work. The more control, the less likely they were to die of coronary heart disease. And not surprisingly, the amount of control they had related to their rank. The higher the rank, the more control. Now, I think Jimmy's experience could attest to this, the issue of control. Before he worked at the Aboriginal Controlled Health Service, he worked in a job where he had very little control at all, and he knew that was pretty stressful. When he came to work at the Aboriginal Community Controlled Health Service, he found he was regularly consulted by his managers about the work he was doing. He became a member of the Occupational Health and Safety Committee that the organisation ran, so he felt he had some power there. And he's also allowed to plan his day as he likes, so that it fits with his rest of his life, so long as he gets his duties done. And he knows, he could attest to the fact that that sense of control has caused him less stress, it's enabled him to reduce his alcohol use, and it's enabled him to quit smoking much more easily. So I hope you see that this health in all policies in areas such as urban planning and employment really show the importance of government policy in shaping our health. And it's really important that governments do monitor the health impact of their activities. And health impact assessment is a great way of doing this. My team and I have been working much with Professor Peter Sainsbury, Professor Liz Harris, and Dr. Patrick Harris and Jen Kent from this university on trying to improve the health impact assessments of urban planning and transport choices. And it's not easy work to do, but I think it's really important work, because if we can convince governments that by not doing that assessment it's going to cost them a lot of money through people's distress, through the health system, then I think that's going to be a very important contribution. My team is also recognising that our worlds are not only shaped by government policy, but more and more by those of transnational corporations. Many of those corporations are now larger than countries, and we know that they produce goods and services that really shape our lives. For example, I think most people know that there's an obesity epidemic worldwide, which in the last 30 years has seen more and more of the world's population becoming overweight and obese. Often people simply put this down to healthy lifestyle. If only people would eat the right food, do the right exercise, if only they'd take responsibility for themselves. But that really is the tip of the iceberg. Under the surface, there are growing transnational corporations which make their profits from selling precisely that high-fat and high-sugar food that encourages people to become obese, and they spend millions and millions of dollars marketing it. Research has shown that when the import of highly processed foods and soft drink increases, after a short lag, so does the percentage of overweight and obese people in that population. And we're seeing that now not just in rich countries, but in many middle and now increasingly low-income countries. We see it in Australia. We're just about the fattest nation on earth, and high-fat, high-sugar fast food and drinks is a major culprit. A group of us internationally are piloting corporate health impact assessment to look at the overall impact of a corporation within a country. What good do they bring in terms of employment and products? Do they pay fair taxes? How do they use and abuse opportunities to influence the political processes? What impact do their products have on the population? And in the view of citizens, do they act ethically? We're currently piloting this assessment on McDonald's in Australia, and we hope to be able to refine this instrument and then use it to assess a whole manner of transnational corporations, including the type of resource companies that are expanding rapidly in African countries like Sierra Leone, and the logging company which employs Emmanuel. We then hope, from the basis of that health impact assessment, to recommend the ways in which the health impact of these companies can be reduced through both government regulation and changes in their own practices. So examples of effective regulation that protect our health abound. Occupational health and safety, the successive round of policies to regulate the use of tobacco, which culminated in the plain packaging legislation, which has seen smoking decline from its peak of about 70% of the population to 15%. And of course, Professor Simon Chapman, one of your, I think now emeritus professor, has played a major role in that move. We've also seen measures to improve road safety, seat belts, road design, random testing for alcohol use, legislation to ensure our food supply is safe, and very importantly, anti-racism and discrimination legislation. All these show that policy is a very powerful public health tool and the most likely instrument to improve the health of Jenny, Jimmy and Emmanuel, and to reduce the injustices that really affect their life. Now, finally, I want to note the important role of doctors in working for and advocating for healthy communities. Medical practice should personalise medicine in every way it can. And in the future, this will increasingly include adapting technology to individuals' particular genetic and other biological makeup. But it should equally be about ensuring practice is adapted to the social and cultural circumstances of the patient, asking why it is that Jenny isn't able to exercise or eat healthy food, ensuring that Jimmy receives the culturally appropriate service. Medicine needs to be concerned with equitable provision of health services. Globally, every citizen needs access to good quality basic health care, and we can easily afford that, but it just doesn't happen for the Emmanuels of the world. Doctors and other health professionals are powerful advocates for this right and must continue to argue the importance of equitable and fair health care, both within Australia and internationally. The respect that doctors and other health professionals have in the community mean that you're all in a very powerful position to advocate for action on the social determinants of health and persuade governments to adopt the pursuit of health equity as an equally important goal to growing the economy. I've personally done this through our Public Health Association and the People's Health Movement, but I recognise that the AMA has been crucial in lobbying for Aboriginal health equity. I'd also like to highlight Michael Marmot, who chaired the commission that I served on he's been a crucial role model. He's actually a graduate of this university. He's just become president of the World Medical Association, and yesterday he tweeted, quote, "As doctors, we cannot stand idly by while patients suffer from the way our societies are organised." A very powerful message. So to conclude, looking to the future, the health of Emmanuel, Jimmy and Jenny will reflect their own agency and their own decisions, but these in turn will depend on the extent to which those factors below the iceberg of health support their health. Questions such as these will be crucial for them. Will Jenny's salary increase like those on higher income at the same rate? And will her suburb become greener and cleaner and offer healthy food choices? Will Jimmy's health service continue to get government funding? Will his contract be renewed so he can keep his house? Will Emmanuel be able to avoid an industrial accident and move out of poverty as his country grows richer? Or will poor safety measures mean he is injured and his family therefore left destitute? Or will unfair policies mean that, yes, Sierra Leone's economy is growing, but it's just meaning more profit for overseas countries? So the world I envisage for the future isn't one where there is personalised medicine for some, while the underlying determinants of health remain unequal and out of reach for most, meaning that health inequities will persist and likely grow. I look forward to a world in which wealth and income are equally distributed, where assessing the health impact of public and commercial activity is taken for granted, in which the gaps between the rich and poor, men and women, Indigenous and non-Indigenous are minimised. I suspect that such a world will be a good place to live. It would give a general happiness for all of us, I think, which would stem from a sense of equality and equity, and would have a great sustainability from the valuing of both health and the environment. I hope you will all use your power and influence to work for that world. An alternative world is possible and I think increasingly necessary, and you are all in an ideal position to join the voices working and advocating for it. Social injustice is indeed killing people, and you can make a difference by working to reduce that injustice and increase health. Thank you.